and I'll just keep admitting people as they come in. And just so everyone knows who's on, what we're going to do is hold questions to the end, please, and I'll be monitoring the chat. So if you want to put your question in chat, if you have a question, I'll be monitoring those and we can cover those at the end. But welcome to our second My Mouth Works Innovative Oral Solutions webinar with Laura Walls, Dr. Chris Catalano, and Dr. Ray Kiefer. And tonight we're going to talk about dental crowding. So I'm going to hand it over to Laura.
Thanks, Mary. Hi, Ray, you on? I think Ray and Chris are on. I'll introduce myself for anybody new that didn't watch the last presentation. My name is Laura Walls, and I'm a speech language pathologist, and I created the My Mouth Works myofunctional therapy app and platform, and I work closely with Dr. Ray Kiefer, and I've known Dr. Catalano for a long time. And our goal today is to talk about dental crowding, identification from and contributing factors to causes and treatment for dental crowding. And this is going to be a really cool topic because you all see this a lot, and I just want to show you some side views and different perspectives, so you might see your patient in a different light and be able to treat your patient really well. So one of the things that we're looking at with dental crowding is the clinical features of posture. So when your patient comes in, you can see when they're transitioning to the chair, you're looking for a forward head posture. And so with dental crowding, you'll often see this. And you can tell a forward head posture by checking the earlobe. So the earlobe should be right over the shoulders. And in this case here with this patient, she has significant dental crowding. Her earlobe is about 4 inches forward. So it would be called a 4-inch forward head posture. While the other patient, also with dental crowding here, you can see that she has an open mouth posture. Her chin is retracted, and she has sleep apnea with dental crowding. These are the two common postures that you see with dental crowding. The next thing I want you to look at is the structure. And what does it mean to have, everybody knows dental crowding, they typically have a high palatal arch, narrow mandible, tight frenum. Maybe some of you address that, some of you don't. But everybody knows about the high palatal arch and narrow mandible here. And so you can see here, if there's no room for the tongue, the only place for the tongue to go is either forward or in the back of the throat.
Excuse me, Laura.
Yeah.
I'm just seeing the original screen. I'm not seeing the program.
Oh, it's not going.
Is anybody else seeing that?
Yeah, I see the same. It's just the same.
It's the same thing. Can you see it now? No.
Starting.
Thanks. Let me see why it's hung up. Hold on. Let me grab Patrick really quick. Hold on.
I think Patrick was scrolling before. I don't know if it's a clicking, but let's find out.
Hi, everyone. I just joined. I joined kind of late. Just finished up with a patient. So, hi.
Hello. No problem. I think we have a few participants that are running late tonight here in Michigan too. We have a lot of people registered.
Okay.
So
I went to the main.
Okay.
Screen. Technology. Maybe you have to close it or go to Teams. Right there.
I think it's on this, but like it should be. Stop sharing.
the beauty is reboot, right? Plug and unplug. It worked before, so.
How's it?
Yep. No, it was just working 5 minutes ago when we were testing it. So.
It's like on that button. That's what's interesting.
See this thing?
Yeah.
The purple.
It just means we're sharing.
I think you have to turn it off and turn it on.
Okay, let me try going out.
There we
Laura,
go.
oh, there it is. I think I see it now. There we go.
Yes, I can see it.
Can you?
There we go.
There
Yeah.
it is. Yeah.
Is
Is
that
it,
Oh, it's not going on that one, Patrick.
okay?
Let's drag that screen down here.
I can't. Here,
Okay,
let me
So I
that's
just-
see the young woman with the what is dental crowding, the posture.
So these arrows, what we're gonna have to do?
Oh, right.
Go
Okay.
forward on that guy. Backs if you go too far forward. Okay. Let me adjust it for you here.
Hi, everyone.
Hello again.
Hello again.
Here we go.
Okay, thank you. So this is no.
Go off of that. guy.
Okay, gotcha.
Regard this.
I'm gonna start over. Okay, so we're talking. Do you want me to go from the very beginning?
yeah,
Shall we?
Sure.
Okay.
There you go.
Okay.
I need repetition as much as possible. So I love it.
I need training as much as possible. Thank you. Okay, this is our team. My name is Laura Walls, and I'm a speech language pathologist, and I specialize in swallowing and myofunctional therapy. And Dr. Ray Kiefer and I work very closely. We're in neighboring towns, and so we've been working together for over 15 years, and he sends a lot of his patients here, and he's here to talk about some of our stories. And Dr. Canilato and I have been to a couple classes together and have worked together on patients, and he's here from the dental perspective to kind of pull it all together for us. And now I think I have to use this button. Can you see it?
yep.
Yeah.
Yay.
Yeah.
All right, great.
Yeah.
Okay, so when you're looking at dental crowding from a dental perspective, you're looking at the teeth. And Chris, we talked about that too, saying, you know, we don't really look at the midline shift or the posture or how it relates to the teeth. But our goal today is really to see the whole picture and to get there more quickly and efficiently with some objective data ideas. And so what I've done is I've outlined some clinical features that you'll be able to see in your patients that will really help with your treatment plan. So one of the items that we look at is posture and one of the items that we look at is posture. And we look with dental crowding, you typically see either forward head posture, like here. And you can see this is one of my patients and her head is forward. And you can tell that not only just by looking at her, but by calculating where the earlobe is in relationship to the shoulders. So a head that's in a neutral spine position, the earlobe would be over the shoulders. In this case, her earlobe is about 4 inches forward. So knowing what that does to the anatomy, a forward head posture is going to cause bunching of the tongue, which will cause myofunctional habits. And we'll talk about this along the way. Another really common posture with dental crowding is this with the retracted mandible. So this is one of my patients with sleep apnea. She has an open mouth posture at rest. You can see her chin is retracted here, and she has bunching of the tongue into the back of the throat with a lateral tongue thrust. You can see this philtrum here is long because the mouth is always open, but the tongue's pulled back here. And I'm going to talk more about that. So structure, this is what I think you're all familiar with. And so I wanted to bring this in because everybody knows dental crowding includes a high palatal arch, which is here. And they know it contains typically a narrow mandible, which is on the bottom here, but you can see this maxilla is really narrow as well. So when you're thinking about it, where does the tongue go? And what is this in the back of the throat here? This is inflammation. And what is this doing to all the structures that are surrounding this high palatal arch and narrow mandible, narrow maxilla? We also see with dental crowding, Chris, this is one of your patients and you could talk about it. And he kind of came to this conclusion in the last class that he sees with, this is for dental crowding. You see, Chris, the frenum that's attached to these two mandibular tori.
Yeah, or I'll see, yeah, those massive tori associated with that high, like frenum, like that. A lot of times I'll see that attached just to those lingual of the anterior teeth, kind of high up on that tissue. And they just seem to always present with those large tori.
At
so
the bottom.
Fascinating to me.
Yeah, I
Yeah.
think it's so cool. And we can answer questions about that as well. So that's the
Yeah.
structure. But what I want your mind to kind of change and think about is, if I have a structure that looks like that, what is the tongue doing? How can a person breathe? How can they close their lips to nasal breathe? And what does sleep look like? So then we get into breathing, and we're going to discuss this at length during the next class. And so we always look to see, is a person a mouth breather, and probably 50% of the population that are mouth breathers deny it because nobody wants to be a mouth breather. And so we ask our patient, do you breathe from your mouth? They say no, but their mouth is hanging wide open. And so that might not be the best question to ask them on your questionnaire. And so what you look at is, how long can you breathe how can they breathe through their nose when they're sitting in your chair? From your health history, maybe do they suffer from allergies, sinus surgeries, high nasal resistance? And you want to find this out on the history, because it indicates a lot. It tells you what's the tongue doing? What's the sinus complex? What's the function of the sinus complex? And how does this relate to dentition? The other thing that we see so commonly is that patients with sleep disordered breathing and sleep apnea also have commonly narrow arches, and the tongue has no place to go. So kind of take your mind and wrap around, okay, here's our structure, but what's the function of the structure? And why is it causing these sequelae like sleep disordered breathing and sleep apnea? And why can't I have good retention with my patients? So the clinical features of dentition, you guys know, it's crooked teeth, twisted teeth, overlapping teeth, high fang teeth. And here's a couple pictures that show that. But again, I want you to think about, how did the teeth get like that? Do you think it's only genetics? So from my experience over the past 30 years, when you're looking at crowding like this, and you see these lower incisors, and you see one pulling back and one pushing forward, that's showing a reverse swallow. So often what would happen is this person would have a lingual bar put in back here once they had ortho. But what happens then is the tongue stays on the resting posture on the floor. It's called a low resting tongue posture. So it occludes the back of the throat. And Ray, you want to talk about the lingual bars?
Yeah, lingual bars are very common. They can come in two different ways of making them. They can be connected to the first molars. If I use that kind of a lingual bar, I'm usually in a mixed dentition stage. The molars are banded, and then there is a round wire that follows the contour of the lower teeth. And really what I'm trying to do is maintain space for the erupting teeth and prevent collapse of the posterior teeth. After full dentition treatment, I will, on the kids that I suspect that won't wear it, or adults, I will often put in a lower fixed retainer that's connected to the canines. There's different kinds. Some can be connected to each and every tooth. I like the ones that are just connected to the canines, just so they can floss and brush underneath the wire. You already covered it. I try not to put them in on people that have like an open bite or tongue thrust, at least if I started with that, just because it can become a point of interest and promote poor tongue posture.
That's it. Yeah. And so anything in your mouth, if you have the little buttons on, or if you have a cold sore, or you've bitten your cheek, our tongue wants to go to that place. And so the goal of myofunctional therapy is really controlling tongue posture so it's resting on the roof of the mouth. And so if you have a reverse swallow or a lingual bar, they're just going to play with that. The tongue's going to stay on the floor of the mouth, which then inevitably ends up often going into the back of the pharynx or the throat, occluding the airway. Next.
You know what I see long-term as a dental? So I see a lot of the adults that have had the lingual wire placed on the lower canines, is I see posterior collapse. So yeah, they're lower. And then what happens is the bicuspids go lingual. Canines almost look like they're flat across, like the lower anterior teeth are kind of almost flat in the front. Upper teeth are the same. The canines start kicking out on the uppers, and then you get this collapse of the bicuspids. You get this weird it's almost like a rectangular shape arch rather than a nice
Yeah.
U-shape arch long term. So this is what I
Yeah.
see when they're in their 30s and 40s, and then they go into Invisalign and straighten it. But yeah.
Chris, that can be from long-term memory of the wire. That wire started out straight, and over time it can
Okay.
turn. So it's like a reverse orthodontic treatment from lingual braces or what have you.
Interesting.
If it's straightening out, then that's going to have a tendency to flare those canines.
Well, so would the myofunctional habit,
Yeah,
right?
Yeah.
It would be a combination. So, and I think you can bend the bar with the myofunctional habit of sucking in the lips and the cheeks and pushing the tongue against it. Is that right?
That's possible. Yeah, I think that's possible too.
Yeah.
But you would know better than I would.
Right.
Yeah.
I've been drilling it in you for long enough, that's for sure. And so start looking at the function of the articulators and as well as the structure, obviously, because that's your job. But we want to pull this all together. So we look at posture, we look at breathing, we look at the structure, and then we look at the jaw. And a lot of patients with dental crowning, they come in, even kids. I just had a dentist text me today and said, I have this 10-year-old that just had extractions and she's having terrible clicking, popping, and jaw pain. Can you help this case? And of course, and that kid had dental crowding, so they did extractions. And so with that, it seems like it just keeps stacking on top of each other, all of these issues. And probably by the end of me drawing attention to you guys are going to be like, what the heck? This is so much information. But when you start looking at it in a sequence, it's so effective and you'll start seeing trends in your patients and then have a treatment plan for that. And that's my goal, is to bring awareness and then start talking about treatment. So this is just a fun fact. And
Laura,
a lot
can
of
I ask-
people, yeah.
One question, can you, so if for dental crowding, and the way I understand it from what I've learned from you is that, you know, it's the dysfunction of the tongue and how we're swallowing. What, for those that, so I recognize that as when I see this, so that's what I'm looking for when I see crowding. I'm looking for tongue function and this and that. Can you explain to everyone what is the optimal tongue swallowing? What kind of teeth will we see?
Yeah, for sure. I'm definitely gonna go into all that.
Okay, good.
Yeah, I'm gonna go into all that, and I'm gonna teach you guys optimal and what you should be looking for. But these are things you might see with dental crowding that you might have not thought about. Oh, hey, this might be a sequelae of dental crowding, right? And so sometimes what we could do is address these functions, which will help with the jaw, lips, and tongue, so that we can promote correct tongue posture. And so by knowing what's going on and then treating that, that's where we get to a good end result. So remember always when you're looking at the palate, high palatal vaults, it goes into this. The palate is the floor of the sinus cavity here. And so you see up here is the sinus complex. And our goal always is nasal breathing, promoting nasal breathing. That's what everybody's talking about. You have to have it during sleep. You have to have it during the day for the autonomic nervous system to respond properly, to keep the stress levels low. So when you have a high palatal arch, it starts growing into the sinus complex here, and it disrupts nasal breathing. And so that's why often you see those people being mouth breathers. Does that make sense?
Mm-hmm.
And mouth breathers often have, obviously, congestion, poor nasal flow, gut issues, inflammation, autoimmune issues. They get sick easily. And so our goal is to get rid of that and get them into nasal breathing. But with a high palatal arch, it's tough to do sometimes. But addressing all of these features, then you can really make some good progress with your patients. I think I'm pushing the right thing.
Can I make one more note?
Please.
Just in regards to all the things that you mentioned as far as the gut health.
Yeah.
I have heard that mouth breathers have a different flora just because it's more oxygenated in the gut.
So breathing through the mouth changes the pH and alkalinity of the saliva. So when they're swallowing it, that's one thing. It does change that. So it disrupts the gut biome. Also, what happens is typically people that mouth breathe often have postnasal drip. And so that's mixed with the bacteria from the sinus complex into the gut. So that creates a terrible situation for so many people.
Yeah, you really helped me with that indirectly. I had that when I did the trials with you, and when you helped me with the with my tongue thrust, I focused on nose breathing, and I had gut issues for almost my entire life, and they're almost gone.
Yeah.
Ever since it marked almost around that time when I started being more consistent nose breathing, lip taping, things like that.
So cool. That's awesome.
Yeah, so
We're
cool.
Yeah, it's so cool. And it's not hard. And it seems hard, and this is going to seem overwhelming, but I'll get it to a sweet spot at the end so everybody understands what's going on. But Chris, to go back to your question about what are the myofunctional habits? What does it look like? What does it mean? So the cheeks are a really good way to check myofunctional habits without going into an assessment for a dentist. And so when you look at the cheeks, you can see, okay, what's going on here? Where's my mouse? So this is linea alba, and most people have probably seen this before. So linea alba means there's a suckling pattern left over from, this is usually from being a 2-year-old, like this little cutie pie next to this mouth. And you can see her cheeks. She still has the fat cheeks, but you can also see here that she's a mouth breather. And so this probably is going to need to be addressed so that she has good sleep. She's definitely at risk. And this would be something from the pediatric population I would address immediately, and it's a quick fix. But what you're going to see in your teen and adult population is you'll see this linea alba. You see it a lot when your patients have clear tray on because they start sucking and there's that little gap in between the molars. But this is something that's indicative of a myofunctional habit of sucking and a tongue thrust, which causes the collapse of the dental arches. And if there's a reverse swallow thrown in there, then changes the front teeth and how they position themselves. This here is cheek biting. So a person that says, I always have cold sores, they might call it cold sores. You can tell that they're biting to stabilize on the weaker side. And so you'll see bite marks in the cheeks or in the lower lip to try to close their lips. Does that help? Even your adult patients, a lot of them, like when we go back to that one patient that had the retracted mandible, she had the puffy cheeks still. That's because she still suckled her food and didn't have good chewing patterns. So with the lips,
the dental description of linea alba for us is clenching. That's how we were taught.
Oh, wow.
Linea alba. And that we didn't realize that there was actually because we never learned myofunctional therapy. We never learned.
Gotcha. That's super interesting. I think with clenching, you do suck in because your mouth everything's tightening, right? And so we're trying to hold everything together and the lips closed. So I could see that being a sequelae of it, clenching. But the myofunctional habit going with it, if you're a suckler and you've never lost that anterior posterior tongue position like this, you're going to get the sucking in for sure. Something else to see in the patient is these dry lips. Napoleon Dynamite's perfect open mouth breather, breathing through his mouth. He never got it together there. And then this tight mentalis is a giveaway for sure for fixing in the front. And that's usually your fat tongue people. And I'll show you a picture of that. So here's the different tongues that you probably see. And I don't know what you guys see most in your practice, but it'd be cool to look at. So this is a long, narrow tongue. And with this tongue, this is a tongue thruster for sure. So this is somebody that only goes forward and back. That type of tongue usually has long face syndrome. We call it diencephalic. So long face syndrome. So they'll eat a lot of carbohydrate foods, softer foods, that type of thing. That's long tongue, long, narrow tongue. They have more difficulty lateralizing the tongue side to side. These are typically open mouth and they get the cold sores on the side. That's this tongue. So check it out to see what kind of tongues you have. This is the wide fat tongue. That's what I have. What this does, it rolls over. You can't even see the lower molars. Do you see? And so for this person,
Yeah.
that's a really low resting tongue posture. It's not even pushing against the teeth. So it's not in the middle of the mouth. It's really on the floor of the mouth. And that's something that you'll see. And then the scallop tongue is a low resting tongue posture. And these little scallops here are the marks from the tongue pushing against the teeth. This is really associated with gum recession, airway issues. Well, for all of these, airway issues. This person probably has reflux, definitely, and might nasal breathe in the day, but nighttime would open the mouth. What do you guys, Chris and Ray, what do you guys normally see in your patients? What type of tongues?
Lots of scalloping.
Lots of scalloping, and then the wide fat, you know. I would say, yeah, the larger tongue that occupies, it can't even fit it in their mouth. It's like it's in the back of their mouth. It's like probably the predominant patient.
Okay, that's so interesting. Both have airway issues of these too. So
Yeah.
that's really cool to look at.
And can you change the shape of a tongue?
Yeah, you can change the shape of the tongue. There's muscles in the tongue. So there's muscles, a long muscle that goes down the center of a tongue. And then there's muscles that cross over. And that's why it's so important to make sure the tongue goes like this and this on the side, but and also can stay on the top, but it connects itself to the roof of the palate. And that is your optimal resting position for your tongue in order to support the cervical spine, in order to keep the jaw muscles relaxed, especially the digastrics. If you're like this and pulled back, this digastric's going to be really, really tight. Dental crowding, you'll see a lot of speech articulation issues with S sounds or Z sounds, and then T, D, N, L when they're talking to you, their tongue's kind of like going forward like this, and it's going in between the teeth. And they spit a lot because they often have an open bite, or there's openings and their mouth is open all the time. Swallowing difficulties with dental crowding would be noticing the tongue when they're swallowing, that their tongue's sticking out between the teeth. They're messy eaters. They like soft foods better. And soft foods, asking your patients, what's your favorite lunch? And people might say, oh, I have soup, or they eat pouches or soft fruits. And so many patients that are sent here, they eat only cut up apples or cut up carrots or only baby carrots, and they eat little small bites. And you can always tell when they're biting from the front like this, these teeth are getting a lot of movement, but the back teeth are probably developing an open posterior bite. And so asking them what they eat, I can't even tell you how many patients that I get here, and they have sandwiches, small sandwiches. They don't eat the crust of pizza. They eat hamburgers, which is considered a mechanical soft, oatmeal for breakfast, scrambled eggs, nothing like biting into an apple anymore,
Wow.
nothing like biting into a big carrot or a piece of broccoli. Everything's cut for them. And there is a great place for cut food for the back to get the tongue to lateralize, but to get that bite on the anteriors really helps set the jaws. And you can always tell when somebody's preparing for swallowing or how the teeth are erupting the side that they chew on, because the teeth will erupt more quickly on the side that's being used. So it's really cool to see if all of the teeth they've lost all of the teeth on one side and the other teeth are a little bit loose. They're not using that side. So there's going to be a structural asymmetry from the jaws to the hips. So it's cool to look at and think about, and just even talk to them like, hey, what'd you have for lunch today? Or what's your favorite dinner? What's your favorite restaurant around here? And kind of just, it strikes a conversation, or have your team do that. A quick thing to ask them to do, I think we talked about this a little bit, but if you look at a swallow, the swallow's pretty much going to talk about the posture, the breathing, the jaw, the lips, and the tongue. And it's a really easy, fast way to do it. So if I'm going to turn my head to the side so you guys can see, but if people go forward like this, they're probably comfortable with the anterior chin position, which means their mouth is going to be open. That's going to be a comfortable position. So if you see them drink and be able to swallow with no water coming out with the masseter, you guys should try it. So take a sip, hold it in your mouth, smile, and then drink and see how it feels. Is it smooth? Does the epiglottis hit really hard where you hear a big gulp? Does the head want to move forward and back to push the bolus into the back of the throat? It's a great strategy. And when you guys have the patient in the chair, you always have them rinse. You know, they could take a sip of water and you could watch it happening. So some things you might see a patient, they turn their cup like this. And so they're only drinking from the one side, right? So you know the structure is going to be off and asymmetric because it's how we use it that the teeth erupt and sit in the place that they're in. Does that make sense? Can you do it, Ray?
Yeah.
Good job.
I've been doing the app. Yes, I can.
Okay, good job. This is a really cool, fast way
Yeah, I can
to
do it.
make. Can you do it, Chris?
Yeah.
So glad. Good job. It really takes about 3 seconds. Like I get it. You guys, you know, you sell time. And so, but to be able to say, hey, is there a myofunctional habit happening here? I want to see how this person swallows and have them do it. You can say, hey, hold
Yeah,
that in your mouth
I
for a
love
couple
that.
seconds. Breathe through your nose. Is it easy? And you'll see people that like, they look like they're, you know, you just dunk their head underwater. They can't
Gonna
access
die.
nasal breathing. Yeah. They won't talk during it. No. And so it's a really cool
Well,
strategy.
we have it every day with our, we have it almost every day with our restorative patients when we work on them because there's so much water as we're drilling. There's so much water coming in their mouth. And so
Okay.
the patient can't breathe through their nose and hold water in their mouth. So they end up like having to swallow and it's, you know, the constant battle throughout the whole procedure. And that is the majority of patients.
Well,
Majority of
why do
patients
you
are like
think
that.
they need restorative work? Do you
I
know?
know.
Why are they clenching? Why are they why are their teeth
Yeah.
getting cracked and cracked? Why is their dentition mixed? You know, what's going on with that? And so many
Yeah.
times you can lead it. Why do people over the age of 45 or 50, why do the lowers always start going crooked? Our posture changes a lot over time. So it's one of those things.
Yeah.
It's a really cool link. If you could look at this picture, posture, breathing, jaw, lips, tongue, just by taking a sip of water, that's easy and
Mhm.
super effective. Then you'll go, oh, okay, hold on. There's something more going on here. So you guys know all these, I think. I'm just going to say it. And I just want you to know there's so many possibilities or potential causes for dental crowding. And I think there's so many schools of thought as to why it happens or what's happening. But basically, these 9, the prolonged thumb or finger sucking or extended pacifier use, we know that typically that suckling pattern that's using collapses the arches. And so many of the kids today drink those pouches, you know, it's crushed food like in a bag because it's easy and it's not messy and they're easy to take places. And so parents give that to kids and it keeps that suckling pattern happening like this. So they're mashing their food with their tongue and not using the teeth to bite. And so the same thing with this prolonged thumb sucking, finger sucking, upper airway obstruction, nasal congestion. Obviously, if you can't breathe through your nose, you're going to breathe through your mouth because of the path of least resistance. But why is that happening? How many people have gotten turbinate reduction or sinus surgery and they have to go back for remediation? A lot, over 50%. Well, the thing is with breathing, it's autonomic nervous system response. We don't think about it. We don't think about swallowing. We don't think about blinking. We don't think about digesting. We don't think about our heart beating. And so what happens is there's a nasal cycle. So one side breathes for 90 minutes. Then the brainstem goes, okay, next one. And then this guy breathes for about 90 minutes. And then they alternate. What happens with surgery is they do the surgery, but they don't train the nose to breathe. And so the thing is, what happens is the turbinates refill up again with nitric oxide, and then they obstruct the sinus complex again. And so with everything we do, there's a sequelae, and we want to make sure that we're doing it in the right way to promote nasal breathing. And so when you're teaching your patient to do that too, you can get them to breathe just by plugging their nose like this and nodding their head like this 10 to 20 times and opening, and they'll be able to breathe through their nose. So you can go, that's nasal breathing. Keep practicing that. So the brainstem could then say, oh yeah, I'm going to make this an automatic habit. If there's missing teeth or an open bite, that's a sign of dental crowding. Poor oral motor function, weak oral musculature, long face syndrome, the big lips, a lower hanging jaw. Genetics play a part in it. Swallowing issues, tongue mashing, eating soft foods we talked about, speech, postural issues, and myofunctional habits. Like, that's a lot of this. And you guys are probably like, okay. And one way to go through this quickly with your patient is just by adding this form into your health questionnaire. And it's 10 questions to go through posture, breathing, jaw, lips, tongue, speech, and swallowing, and sleep. And so this will just tell you if your patient has 5 or more of these issues, clearly they have a myofunctional habit that's contributing to the dental crowding. It's an easy form to use. And now you guys are probably, this picture's so cute because it's from a dentist office. Does everyone know Nemo? Do you guys know the movie? Do you remember? So these
Yeah.
fish, they're escaping the dental office. And I want you guys to escape that way of thinking that it's only the structure that you're fixing. I want you to think about it like, okay, what's the alternative? What can I do to make this better? How come I'm seeing these trends? Like Chris, you're saying you have bilateral mandibular tori with a thickened frenum. Why is that the lowers are clenching so hard and they're breaking down? Well, clearly they don't have a good jaw tongue ratio, which is a TRMR. It's a tongue ratio where you open your jaw and you put your tongue up. And so what do they consequently do? They have tight sublingual and digastric muscles and they pull backwards, and all they can do is clench their teeth. And so then what happens consequently is our bones say, oh, I get it. Where I'm clenching, so I need to make bigger bones to hold these other bones in place. And so I'm going to throw off all these osteocytes that create these tori to help try to salvage the teeth and keep them in place. But then what happens is the sequelae of that is there's no room for the tongue. So now we have this whole buildup, and it's like, now where does the tongue go? It either goes forward and we open the mouth, so we have a mouth breather and gut issues and health issues and sleep issues, or it goes into the back of the throat, and then we get an obstructive sleep apnea. So what do? Ta-da! Now we go into how do we treat this? And so what we've created at our practice is we've taken the past 15 years and we put our exercises into play, and we created a MouthWorks platform that incorporates all of the exercises that we've done per diagnosis, including dental crowding, so that each dentist can go ahead and treat their patient in their own practice without having to have access to me or another myofunctional therapist. Super effective. It's easy. It makes money for the dentist, and it also isn't expensive for your patient, but it's very effective. And so what we do is our team will set up a demo, and the My MouthWorks team will brand the app for your practice. So this is mine, Innovative Oral Solutions. There's another one, Sinclair Smiles, and another one, White Birch. So we'll skin it to have your own logo on there. And then what we do is link this to your Facebook. We can go ahead and link any of these to your Instagram. You can promote specials on it, and then they can click and do their exercises. On that app, what we do is we follow the patient and look at, from an algorithm perspective, what are the trends with the different diagnoses and how they're doing well on their exercises. The other thing Dr. Kiefer and I created was the OPA, the oral placement appliance. And Ray, do you want to talk about this a little bit?
Gosh, how long ago was that?
It was a
10 plus years
while ago. Yeah. Mm-hmm.
So I felt like Laura was managing the issues with, like, it was really with linea alba and scalloping that I had become aware of. And I felt like people, as long as they were good at doing their exercises and therapy, could manage it during the day. But I saw this disconnect when they were sleeping and, clenching, grinding, poor tongue posture, or sleep. So I came to Laura and said, hey, let's create a device that can get in between the cheeks and the teeth and in between the teeth, and then at the same time position the tongue in an ideal position.
Yeah. And so I use this for nighttime management for correct tongue placement. And it's super effective for so many of my patients, and people that love it, they love it, and it's awesome. And it takes anywhere from 3 days to 3 weeks to get used to it. It's an off-the-shelf product. You can trim it to suit the patient's mouth size. We typically, what we do, which has been really successful, is we have them wear it as is for 1 week, and then we have them come back in during their next appointment and we say, okay, how does it feel? Do you need any trimming? We look to see what's going on. And a lot of times the linea alba will be lighter in color and you can see the scalloping of the tongue gone. And so we know that we're promoting that correct lingual placement. So one of the things that we didn't realize during the study and during the FDA clearing process is what it did was promote good REM sleep. And so people responded on the study to say that they were having really vivid dreams. And so that was super promising to know that we were the correct tongue posture and stopping of grinding really helped with the sleep quality as well. And
that was me. And, you know, I had that, you know, I will say that the tongue bowl part really helps train my tongue. It's a great training tool at night. So it keeps your tongue lifted and.
Right, you can kind of see it right here. So what we've done is here's the wings of the oral placement appliance.
You need to back it up.
Sorry, thank you.
You go back.
I'm going. Got it.
There you go.
Yeah,
Thanks,
right there.
I can't see you, so your secret's safe with me. I can only see these screens. Okay, so right here are the wings, and Dr. Kiefer, that like he said at the beginning of this, one of the things that were causing difficulty with retention was that linea alba and that sucking in. And so what we wanted to do and what he suggested was that we create these wings to stop that sucking in. This is the bite plate here, which protects the teeth. And Chris, what you're talking about is down here.
That bowl.
The bowl keeps the tongue position from a reflex perspective. It stimulates on the tongue to push it up to the roof of the mouth. So it's a super cool device. And one of the things that's super funny that we also didn't think about, but my kid did it. He woke up and he had these 8 blisters on the inside of his lip. And he had myofunctional habits in grinding. And what we found out that if you suck, it really is a good diagnostic tool to show that somebody's sucking in their sleep, because it made these little blisters. You can cut those out though, but it's a good way to check what's going on at night for sure. Yeah. So this is a really cool product as well. And we incorporate that into the My Mouth Works app. And the OPA is part of it for dental crowding, sleep, and for TMD as well. It's really cool. So that's our spiel on dental crowding. I hope, does it kind of give you a clearer perspective of how other things influence the dental crowding? Does it make it clearer?
Yeah.
Definitely. Laura, I have a question for you. It's Mary. So if someone's in traditional splint therapy, which is what, you know, most people are doing with TMD, what would be how would you switch them to the OPA? And is it more like a deprogramming type of thing, or?
Oh, that's a really good question. I think I can answer it from a perspective, from my experience perspective, and Ray and Chris, you could probably talk a bit more from a dental perspective. But so for how we do it is we have them wear the OPA during the day, and typically when they're walking, hanging out on the computer. And so what it does, the side wings relaxes the masseter muscles. And so I think the difference between the splint and the OPA is it's actually relaxing the muscles and promoting the correct placement in a symmetrical plane. Whereas I think, but you guys correct me if I'm wrong, I think splints are built up to cause relaxation. It puts them in where they think the muscles or the mouth wants to be. Is that right, you guys?
It depends on, I mean, sometimes splints are made flat and I would say an orthotic has the indents to position the jaw in a particular spot. So my only comment on the splints versus the orthotics, if you're trying to manage grinding, the grinding, I think, is typically coming from an incomplete airway. So then if you add a big slab of plastic to the top teeth in particular, you're forcing the tongue back further. And that's why I will often see people not tolerate the maxillary splint very well, because it's challenging their airway even more.
Yeah, that's super
Mhm.
interesting.
Yeah.
Where Chris,
And
do you have
I
experience with that?
yeah, I have found that that traditional maxillary splint, again, like Ray's saying, it just, you can still clench with the same kind of intensity. You're just in a different jaw position. So you get, I mean, you get like, I don't know what the statistic is, but it's like 50%, which of the benefit from it. A lot of anterior deprogrammers are used, which can cut down clenching intensity. And but I found that the OPA device, when I wore it, I did cut off the wings, and it felt a little bit like an anterior deprogrammer. It was like almost like a combination for me. But I found that the tongue lifted prevented me really from clenching. It was kind of interesting. I didn't clench with the same intensity on that little device, so it did relax me more.
So I'll
But
show
with
you.
flat plane splints, you can still clench. And what you can do is have a patient clench together without any device, feel their temporal muscles, pop in a maxillary night guard, have them clench, and you'll feel the same bulge. If you do it with an anterior deprogrammer, you'll change that. And if you do the OPA, you can see how it's changed. It doesn't, you can't clench with the same intensity. So
Yeah.
it does.
The idea with NTI's anterior positioners, for us anyways, sometimes it creates that moon in the teeth. And the idea, I think, but everything I've
Yeah.
read, it was supposed to be short term. So it was kind of during remediation
Yeah.
of why those muscles are so tense, and then doing therapy to help calm
Yeah.
the muscles down and then ditch it. But people wear it forever. But I think those are for what we base this off. We built up the anterior portion right here. You can't really see it up here, but of the OPA, about 3 millimeters. The back is 2.5. So it's 0.5 of a millimeter higher. So it gives that kind of idea, but it's soft. There's 2 durometers.
Yeah.
So it kind of takes off the clenching from here and makes you put more into the anteriors. And so it gives more of an equal bite, was the idea behind it.
Yeah.
Mm-hmm.
Yeah.
But it's FDA cleared for eliminating maladaptive behaviors, normalizing swallows, and correct tongue placement was the idea. That's how it was FDA cleared. Does that answer the question, Mary?
It does. Yeah. Thank you. Thank
Yeah.
you.
Yeah.
If anyone else has questions, you can put them in the chat.
How can I see
And
them?
going back to, I wasn't sure if the people that were on realized we are recording this. We will have the ability to review it later. So if there were some really nice checklists that you gave Laura to add to their health history and interviews with their patients, you know, those will be available after we just archive the footage here from tonight.
Okay, yeah. Anybody can always contact me, and I'm happy to go over this individually with a doctor or their team to show them how this all works and comes together as well.
One of the things I asked last week, but I thought of sort of a follow-up question to Laura, was when the doctors are bringing in the patients for these particular issues, is this part of the initial oral examination, or do you identify it, say, in the hygiene chair? And then obviously, Dr. Kiefer, maybe not for you in hygiene, but if, you know, how do you identify? And then would this be a follow-up exam to address these specific issues, just in terms of the logistics perspective?
So I think, Ray,
Yeah.
you do it a little bit differently, but how we've trained dentists to do this with the My Mouthworks app is we have it as part of their initial consultation and
Okay.
or consultations coming in for complaints. So if somebody comes in with jaw pain or relapse, or they're starting to have headaches, then we start asking these questions again, and that's been really effective.
Good. Okay.
Mhm.
that helps.
Yeah.
Thank you. Okay, I don't see any other questions coming through chat. So we can probably wrap it up for this evening. Next week, we'll be doing sleep, same time, same place, 7 p.m. Eastern, 4 p.m. Pacific. And I thank Laura, Dr. Kiefer, and Dr. Catalano again for your wonderful presentation.
Thank you. Thanks,
Thanks
guys.
so much, everybody.
Thank
Have a
you.
great night.
Bye.
Bye-bye.
All right, thanks.
Thanks.